What's up, Ninja Nerds? In this video today, we're going to be talking about pulmonary artery hypertension. This is part of our clinical medicine section. And if you guys like it, it helps you, please support us. And you can do that by hitting that like button, commenting down in the comment section, and please subscribe. Also, if you guys get a chance, I really urge you guys to go down in the description box below. There's a link to our website. Become a member. There's a lot of cool stuff that we offer there. Notes, illustrations, questions. We're developing exam prep programs. So I really, please take a look at that stuff. Also, if you guys are interested, we have some actual merchandise that you guys can check out as well. All right, let's start talking about pulmonary artery hypertension. So pulmonary artery hypertension, within the name, it's the high blood pressure within the pulmonary circuit. And generally that number is a mean pulmonary artery pressure of greater than or equal to 20 millimeters of mercury. So if it's greater than that, then we say that the patient has pulmonary artery hypertension. The question is, why is that pressure in the pulmonary circuit so high? It shouldn't be very high. Well, the reasons why is these right here. There is a fifth one, but we don't actually mention it within the pathophysiological process here because it's multifactorial. But the first one that we're going to talk about is type 1. So type 1 pulmonary artery hypertension is idiopathic, meaning we don't know why it occurs. What we suspect is due to is what's called a BMPR2 mutation. So this is a gene that's supposed to regulate the balance between your vasodilators and your vasoconstrictors within the pulmonary circuit. So let's say for whatever reason, the vasodilators are downregulated, all right? So they're shut down. Whereas the vasoconstrictors are upregulated in this particular circuit. So if you have this mutation, what it's going to do is it's going to decrease the vasodilators and increase the presence of your vasoconstrictors. So if I decrease my vasodilators, what would be some of those particular chemicals? Nitric oxide, prostacyclin would be another one, and then the vasoconstrictors would be things like endothelin. This is a very potent vasoconstrictor. Now, if I cause this type of imbalance to occur, what do you think is going to happen? Well, the end result is obviously there's going to be less vasodilation of the pulmonary vessels and more vasoconstriction. So these vessels will constrict like a son of a gun. If they do constrict, what this will do is this will cause the pulmonary vascular resistance to go up. So the ultimate effect here is you're going to have what's called, we're going to say here, right above, pulmonary vasoconstriction. Now, this pulmonary vasoconstriction will cause the pulmonary vascular resistance to go up. So if the pulmonary vascular resistance goes up as a result of this stimulus kind of process, then what's going to happen? The resistance in this pulmonary vessel is going to be really high. That means that the pressure is going to have to be generated much more higher within the right ventricle to push blood into that pulmonary artery. When resistance goes up though, what does that do to the pulmonary artery pressure? That will increase the pulmonary artery pressure. So then the patient will develop an increase in the pulmonary artery pressure, which will lead to pulmonary hypertension. And that is the process that we discuss here with type 1. And again, the primary etiology here is that these patients are developing some type of BMPR2 mutation. And this is what we refer to as idiopathic, meaning we think it's due to this mutation, we just don't know why these patients have this mutation occur. All right, that's type 1. Type 2 is different. This one has nothing to do with a genetic mutation, it's actually due to left side heart failure. So when a patient develops left heart failure, particularly one of the things that occurs here is that they develop a very high left atrial pressure, right? So when patients have heart failure, so let's say that this patient has left heart failure, one of the interesting things that occurs here is that their cardiac output drops, whether it's diastolic or systolic. And then what happens is their left ventricular end diastolic pressure usually goes up as a result of their left heart failure. That makes it really hard for blood to come in from the left atrium into the left ventricle. So this process will become inhibited. And as a result, what will end up occurring is blood will backflow via the pulmonary vessels, the pulmonary veins. And this will increase the patient's pulmonary capillary wedge pressure. Now, when the pulmonary capillary wedge pressure goes up, what this will do is this will cause a lot of the actual vessels to become very congested with blood. If the pressure in the capillaries is high, it's going to be harder for blood to run through the arterioles and then into the capillaries, into the venules. This is making it really hard. So this leads to a lot of what's called pulmonary congestion. And that pulmonary congestion will then lead to higher pulmonary pressures. So then what will happen is the pulmonary artery pressures will go up and pulmonary hypertension will ensue. And that is the process here. So there's going to be increased pulmonary congestion and increased pulmonary artery pressure that will precipitate pulmonary hypertension. Again, the primary etiology here is going to be left heart failure. That's the trigger of this. All right. So if a patient has left heart failure, that's group 2 or type 2. If they have a BMPR2 mutation, that will then trigger this process. All right, what about type 3? So type 3 pulmonary artery hypertension is going to be when a patient has no left heart failure with elevated pulmonary capillary wedge pressure, no problem with a mutation causing increased constrictors and decreased dilators. In this scenario, there's one thing that's causing intense pulmonary vasoconstriction, and this is hypoxia. So when patients develop things like they have, for example, let's say chronic obstructive pulmonary disease or interstitial lung disease or obstructive sleep apnea or OHS, all chronic lung diseases. In these scenarios, what happens is their lungs fail to properly oxygenate blood, and these patients develop hypoxia. Now, if it's just acutely or transiently, that's not a problem. It's when it's chronic. So when patients have chronic hypoxemia, this is a very potent pulmonary vasoconstrictor. And so what it'll do is it'll actually go to these pulmonary vessels and cause pulmonary vasoconstriction, similar to what we just talked about up here. So now they're going to have increased pulmonary vasoconstriction. Now I'm going to narrow the pulmonary vessels. What is that going to do to the pulmonary vascular resistance as an effect? What will that do? It'll make the pulmonary vascular resistance go up, which will increase your pulmonary artery pressures. So if I then, by default here, increase my pulmonary vascular resistance, increase my pulmonary artery pressures, and it goes greater than or equal to 20 for the mean, that'll be what? Pulmonary hypertension. And this is how we would kind of go about the patient having type 3. So type 1, BMPR2 mutation, imbalance in constrictors, dilators. Type 2, or group 2, left heart failure, increasing post-capillary pressures. Type 3, hypoxic vasoconstriction causing increased resistance and blood flow. What about the last one? Type 4. Type 4, we also sometimes abbreviate this one CTEPH, but the primary problem here is that these patients develop clots within their pulmonary arteries. Usually they're not like large ones, they're usually small, like segmental clots. And what happens is that when you have these pulmonary emboli, so let's say that these patients have pulmonary emboli, but they're chronic pulmonary emboli. So sometimes what we call this CTEPH. So it's chronic thromboembolic pulmonary hypertension. In these particular scenarios, you're having a clot occlude blood flow. When you have a clot occluding blood flow, what is that doing to the pulmonary vascular resistance? It's pretty straightforward, right? This is going to increase the pulmonary vascular resistance, just naturally because you have a clot there. And if you increase pulmonary vascular resistance, what do you do to the pulmonary artery pressure? What happens to the pulmonary blood pressure? It goes up, and if it goes greater than 20 mean, then we have pulmonary hypertension. And that's the concept here for these. So again, type 1, imbalance. Type 2, left heart pressures. Type 3, hypoxic vasoconstriction. Type 4, chronic pulmonary emboli. There is a type or group 5, and in that one it's multifactorial causes. There's no clear defined mechanism, so we're not going to go into it a lot. But now what I want to do is talk about the complications or features that are important to remember in patients with pulmonary hypertension. All right, my friends, so now when a patient develops pulmonary hypertension, that pulmonary artery pressure is really perking up there, right? The patient's right heart really takes a big hit from that. It puts a lot of strain. So imagine having these like super high pulmonary artery pressures. What's going to happen is the right ventricle will start to have to develop an intense amount of strain. So I think one of the best ways to think about this is that the pulmonary artery pressures are really pretty stinking high. So let's say up here that these patients have these mean pulmonary artery pressures of at least, some will say greater than 20, some will say greater than 25. Some of the newest literature says greater than 20 millimeter mercury. Some will also say 25. But either way, mean pulmonary artery pressure is high. If it is high, what happens is this will then transmit to the right ventricle to say, hey, right ventricle, pulmonary artery pressure is pretty high. You better start thickening up. And so what happens is, let's say here's the blood within the actual right ventricle. It wants to be able to push this blood out here. But because of the actual high pulmonary artery pressure, this is inhibited. If this is inhibited, the blood will then not move this way, and it'll start to back up into the superior vena cava and into the inferior vena cava. And so this leads to what's called, what we lead to explaining as the high central venous pressure. So patients will have high central venous pressure. This is basically a measure of right atrial pressures. If this is high, and it's really high, it can start causing blood to back up into these vena cava circuits. If it backs up via the superior vena cava, it can then back up and cause distension of your jugular veins, which can cause what we say jugular venous distension via high jugular venous pressures. The other thing is if it backs up via the inferior vena cava, it can back up and cause congestion of the hepatic veins. So if you lead to what's called hepatic vein congestion, it makes it really hard for blood to leave the liver. And if it's hard for blood to leave the liver, it can cause the liver cells to become congested, and as a result, they can become injured and then get swollen. And so these patients often develop sometimes what's called hepatomegaly, which over time actually can lead to sometimes cirrhosis or liver failure. So we'll put liver failure, but this can look like cirrhosis in some of these patients. So that's generally the way that these patients can present in this particular fashion, right? From increased hepatic vein congestion. The other thing is they can really bog down the portal veins. They can get really, really high portal venous pressures. When you develop high portal venous pressures, what happens is a lot of fluid leaks out of the peritoneal capillaries, so we call portal venous pressures. And if those peritoneal capillaries start having very, very high capillary pressures, hydrostatic pressures, they start pushing fluid out. Portal venous pressure. And what that'll do is that'll accumulate into the spaces in the peritoneal cavity. And when it accumulates in the space of the peritoneal cavity, these patients will start developing something that we call ascites. All right, so they can develop ascites. This is usually what's called a low sag kind of ascites, but we'll talk about that when we get into GI. But ascites will be another potential presentation. And lastly, if the central venous pressure is really, really high, it can actually move down to the lower extremities and cause edema of the actual lower extremities. Now, this is the primary way that right heart failure will present. But pulmonary hypertension is very interesting. In patients who develop pulmonary hypertension, one of the most common presentations, the number one presentation, is actually going to be something very interesting, which is a part of this kind of right heart failure kind of thing, if you want to think about it. In patients who develop pulmonary hypertension, they have a really difficult time getting blood from the right heart into the left heart. Now, if you have difficulty getting the blood from the right heart into the left heart, you're going to drop the left heart filling. You're going to drop the actual cardiac output of the left heart. When you drop the patient's left ventricular cardiac output, especially during exertion, you can't perfuse the brain, you can't perfuse the coronaries. And oftentimes these patients can develop two particular presentations that is really important to remember. One is dyspnea, and the other one is syncope. But this is usually exertional. So both of these are usually exertional. But I would say the dyspnea is going to be about 80% of your patient population who will develop this type of symptom. All right, so this is going to be some of the number one presentations in combination with features of right heart failure that you want to remember for patients who have pulmonary hypertension. All right, now let's talk about how to diagnose it.
Okay, how do we approach pulmonary hypertension? This is a tough disease, but I think one of the biggest things is to say, okay, let's get an echo. Because an echocardiogram is really great because it looks at the right heart pressures. So if I get that, and let's say that I want to rule out or rule in type 2 or class 2, which one was that one? That was left heart failure. I'd be able to do that because it would tell me, oh, is the left ventricular end diastolic pressures really high? Or is the left ventricular ejection fraction really low? Because that would tell me that it's left heart failure. But the other thing it would tell me is that I'd be able to get a look at the right heart and see, oh, what's going on with the right heart pressures? Is the right heart pressures really, really high? Is there a dilated right ventricle that's causing the septum to become flat because I can't get blood out of the right ventricle because the pulmonary pressure is so high, right? Or is there a reduction in the right ventricular systolic function? Look, this is the left ventricle here. Here's the left atrium. Here's the right atrium. Here's the right ventricle. Look how huge this right atrium and right ventricle is. It's dilated, the septum's flat, and their systolic function is garbage. This is really supportive of pulmonary hypertension. There is other tests that you could do. Chest x-rays could show a pruning of the pulmonary artery. EKG could show right axis deviation, right bundle branch block, right ventricular hypertrophy, but they're not going to be definitive tests. This is a really good test to get you started off with. I would always pick an echo over the chest x-ray and ECG for pulmonary hypertension. But if I wanted the most definitive diagnosis, it's a right heart catheterization. You take a catheter, you run it down through the jugular vein into the right atrium, pulmonary artery, and then you run it up to the pulmonary capillary area and you inflate the balloon. And what happens is it should give you a pressure of the pulmonary arteries. And you get what's called a mean pulmonary artery pressure. If it's greater than 25, that's really concerning, and that's definitely suggestive of a patient having pulmonary artery hypertension. On top of that, if their pulmonary capillary wedge pressure is normal, that also rules out class 2. And if their peripheral vascular resistance is pretty high, that's also suggestive of pulmonary artery hypertension. But I think this is the most well-known one right here. So if I get an echo and maybe even an EKG and a chest x-ray that's suggestive of pulmonary hypertension, get the right heart cath. That's the definitive diagnosis to confirm pulmonary hypertension. Now, if I've done that and I've gone through, and let's say I ruled out type 2 or class 2 because their echo does not suggest left heart failure, then I'm still left with type 1, I'm left with type 3, I'm left with type 4. Class 5, don't even worry about it. That one's kind of like that multifactorial one. But I got to work up all the other types. I got to rule out class 3. So I'll get PFTs, I'll get a chest CT scan, a VQ scan, and all of these things are going to tell me. So if PFTs will tell me if I have an obstructive lung disease or interstitial lung disease. Chest CT will help me with that as well. Tell me if I have like a pulmonary embolism or a chronic PE. VQ scan will tell me if I have a chronic PE. So this will help me to rule out like your type 3 and type 4, class 3, class 4, pulmonary artery hypertension, and the echo would be really good at being able to rule out class 2 or type 2 pulmonary artery hypertension. If I've done all of these tests, the echo, rule it out class 2, the workup for PFTs, chest CT, VQ scan, sleep study, all of that, and I've ruled out class 3 and 4, the next thing is at this point, I've pretty much gone to the point where I say, okay, I'm probably at class 1. But again, if I have abnormal PFTs and abnormal CT, I can then rule out or in type 3. And again, if I have an abnormal VQ scan, I can rule out or in type 4. So that at that point, if I've gone through everything and I've worked up everything and I got a normal workup, it's likely type 1 pulmonary artery hypertension. Because all of these, type 1 all the way to type 5, will have elevated mean pulmonary artery pressure and an increased PVR. But the one who's going to be due to type 1 is they have a negative workup for everything else. All right, how do we treat pulmonary artery hypertension? Well, in this patient, I really want to determine what type they have. Because in class 1, that's the only one I'm going to use vasodilator therapy. And if they fail, a heart-lung transplant. All right. For class 2, class 3, class 4, and class 5, it's all about treating the underlying disease. So I'm not even going to worry about that. I'm just going to talk about class 1. If a patient has class 1 pulmonary artery hypertension, what I do is I do what's called a vasoreactive test. So what you do is you give them a calcium channel blocker like nifedipine, and you measure the mean pulmonary artery pressure before and then after you give them the calcium channel blocker. If you give them the calcium channel blocker and it dilates the pulmonary arteries enough that it drops the mean pulmonary artery pressure a decent amount, then that means the vasoreactivity test is positive. In these patients, you treat them with that calcium channel blocker pretty much lifelong. If the vasoreactivity test was negative, so in other words, you give them that calcium channel blocker, their mean pulmonary artery pressure didn't drop very much at all, then this is not going to be something I'm going to put them on lifelong. I'm going to give them drugs that helps to treat the imbalance between the vasoconstrictors and the vasodilators. In other words, I want to shut off vasoconstrictors or increase vasodilators. That's it. So how do I do that? Endothelin antagonists, basically, I want to block the vasoconstrictors. I want to decrease the amount of endothelin present. PGI2 antagonists like selexipag, it's going to, again, increase the amount of vasodilators. PDE inhibitors, like phosphodiesterase inhibitors like sildenafil, this is going to, again, increase my vasodilators. It's going to increase my prostacyclin, increase my nitric oxide. Both of these scenarios, if I increase my vasodilators, decrease my vasoconstrictors, it's going to cause reduction in pulmonary vasoconstriction and reduce the mean pulmonary artery pressure and reduce the right heart strain, reduce the risk of right heart failure. That's the concept that I want. In patients who have very severe or refractory pulmonary artery hypertension and they're in the ICU, sometimes they may need IV prostacyclin antagonists like epoprostenol or inhaled nitric oxide. So these are things to potentially consider. But that would cover the treatment of pulmonary artery hypertension. And that covers this lecture. I hope it made sense. I hope that you guys enjoyed it. And as always, until next time.